quote, an area of remarkably weak evidence built on shaky foundations. And Cass recommended a fundamentally different model of care. Gender questioning children should be cared for just as well as any other young person, and that care should be safe, holistic, and effective. Now, obviously, I'm not going to list the 32 recommendations, but Cass said that everyone going forward should receive a thorough assessment which screened for neurodevelopmental conditions and explored mental health. Other approaches, not just blockers, to managing distress should be used. A data linkage study, which was originally thwarted by the adult gender clinics, should go ahead to better understand the long-term outcomes, or understand them at all, for the thousands of children seen at GIDS. A new puberty blocker trial should be established to try to fill the gaps in the evidence base. Has this gone off? Oh. And Cass also recommended bringing forward a new review of the adult gender clinics, establishing follow-through services for 17 to 25-year-olds, and separate services for those wishing to detransition. That's just a few. Now, that last one I think is particularly important because it's an acknowledgement of mistakes, that some young people were indeed sent down the wrong path for them. And I think actually implicit in all of what Cass writes and recommends is that these things were not done at GIDS, otherwise why would you recommend doing them in the future? And we can only make the future better if we learn from the mistakes of the past. So I think it's worth reflecting on what and how this went very wrong and the multiple missed opportunities there were along the way. So GIDS was founded in 1989, and for 20 years the service was mostly therapeutic and small. That changed in 2009 when it was nationally commissioned by the NHS. And now you may well have seen this graph before, I'm sure many of you have, but it's always quite striking. From 2009, you can see the referrals start increasing by roughly 50% per year, and then between 2014-15 and 15-16, they double. And in 5 years, there's a tenfold increase, from 139 to 1,419. And at the same time, the sex ratio of those being referred shifted dramatically too. Do forgive my gender stereotypical pink and blue. It's purely a visual device. From 2/3 male historically to 2/3 female by 2015. Many were girls whose gender-related distress had begun after the onset of puberty, not historically been the case, and who often had complex needs. Crucially, no one stopped to ask what the hell was going on. What GIDS offered these young people at this time changed significantly too. So GIDS became an assessment service, deciding if children could be referred for puberty blocking drugs. And in a very small number of cases, that could be after an hour or two. It's really not to say that all children, or even the majority, went down that path, but the GIDS leadership were actually pretty open about this at times, that this was the only treatment offered. And in fact, I think this is quite interesting because most of what has taken place has done so in broad daylight. And I wrote in the opening pages of Time to Think that this wasn't just a story about an NHS service using poorly evidenced treatments on some of the most vulnerable people in society, but actually also how so many people sat back, watched, and did nothing. History tells us that people in general, present company accepted, don't speak out. We should learn this. Through the 2000s, GIDS came under pressure to lower the age at which they would offer puberty blockers. A team in the Netherlands were doing it and had some early promising but cautious results on 70 children, 70. So GIDS and their endocrine colleagues at University College London hospitals set out to do their own study to try to add to this limited evidence base. That GIDS study was initially rejected because the team didn't want to include any kind of control group, and the ethics committee judged that there was no way to validate the research and therefore it would be unethical. As it happens, the research was approved, unchanged, by a second ethics committee. And between 2011 and 2014, 44 children aged between 12 and 15 were enrolled and received puberty blockers. But it's really, this I think is the turning point in the story, because it's what happens next that is quite so extraordinary. Without waiting for any data to come back from that study, from mid-2014, GIDS began to make puberty blockers available to younger children as routine clinical practice. And we now know without any follow-up either. The lower age limit of 12 was done away with, and it was down to whether a child had entered early puberty. Now, being charitable, this decision stemmed, at least in part, from a desire to help these distressed children feel better. But, and I think it's quite an enormous but, the children being referred to GIDS, and then by GIDS onto endocrinologists at UCLH, were not the children for whom this intervention was ever designed for or intended. The Dutch had said that the only children who were eligible were those with lifelong gender distress, stable home lives, and who were psychologically healthy. This is parliamentary footage, that's why it's very badly framed. But on your far left, that is Dr. Bernadette Wren, effectively the number 2 at GIDS. And here she is telling Parliament about GIDS patients in 2015.
We're not having the sort of more what you might see as the ones who are in the very highly regarded Dutch study, which is this group of now 55 young people being tracked over time, who lifelong GIDS, very supportive family, very few associated difficulties. They represent a very small, that sort of profile is a very small proportion of our young people. The range, in terms of gender binary, we're having more and more young people coming forward with really quite disrupted attachment histories, more looked after children. You know, on a typical referral day, we are really concerned about the complexity, I suppose, of many of the young people coming forward.
Now let's just pick that apart a bit, because Wren mentions there are 55 young people being tracked. Because while the Dutch study originally included 70 children, when the team issued an update in 2014, that group had shrunk to 55, so a loss of about 20%. By now, they'd all been prescribed cross-sex hormones as well as the puberty blockers and had surgery. The Dutch claimed that this loss of 20% or so didn't make a material difference to the findings because at baseline, these kids had been comparable. But that, to use a highly technical term, is crazy, especially when you hear about the 15 who are now not included. One had died as a direct result of surgical transition. 3 more weren't eligible for surgery because of uncontrolled diabetes and morbid obesity. There are also now complete data for just 40, so 57% of the original cohort. And that basically tells us nothing, apart from perhaps this field has never been evidence-based. Back to Dr. Wren.
I work in a service where most of the young people who wish for it, for all of the, most young people, a lot of young people have physical intervention, and anybody who wants it, we have no record of turning people down for physical intervention. But what we offer is not just physical intervention.
And in case there's any doubt about what GIDS were doing here, here's what boss Polly Carmichael told that same group of MPs. This one is written. Treatment not just to those people who are identifiably resilient and for whom there is an evidence base for a likely successful outcome. We offer physical intervention to those who have a range of psychosocial and psychiatric difficulties, including young people with autism and learning disabilities and young people who are looked after. We have felt that these young people have a right to be considered for these potentially life-enhancing treatments. For these children, the ones being described by the number 1 and 2 of GIDS, there was no evidence at all of a beneficial outcome. GIDS took an already extremely weak evidence base and applied it to a completely different cohort. They were open about it. They told Parliament about it. They had the decision approved by NHS England, and no one said anything. By 2016, all the 44 that had enrolled in the study had been on the blocker for at least a year.
So in terms of our early intervention, I guess the other thing is that our results have been different to the Dutch. We're about to publish these, and we haven't seen any change in terms of psychological well-being and so on.
They didn't publish them that came another 5 years later. But by now, 2016, GIDS and their endocrine colleagues had found that the much anticipated improvements in well-being had not actually materialized, as she said. Some children, especially the girls, had got worse. But by now, it wasn't just the 44. By this point, 162 children aged 14 and under had started blockers. And it's at this point that GIDS could have changed direction. Indeed, as Dr. Cass told me when I interviewed her last year, the endocrinologist prescribing these drugs should have reflected whether this was the right course of action. And you might notice that I'm including the endocrinologists at UCLH and Leeds. Most time I mention GIDS because, and that is deliberate, because they were the ones who prescribed and they were medically responsible for these patients. In no other part of their medical practice would these doctors prescribe without having diagnosed or assessed the patients themselves. And yet here they relied almost completely on the judgment of others, a judgment which we know on occasions was exceptionally shallow and poor. Despite those early findings, nothing changed at a service level. When we finally got the results in 2021, they confirmed that they had seen no changes. By then, according to GIDS and UCLH data, more than 1,500 children had been prescribed the blocker. Around this time, staff begin to worry more and more. Staff like Anna and Anastasis don't keep it to themselves. They raise their concerns time and time again, and there's a massive paper trail that shows that. But generally, those who spoke out were scapegoated, labelled troublemakers, and forced out one way or another. One former senior staff member told me this: the more anxious and worried you became, the more it was framed that you weren't really someone who could handle it. It was a brilliant way to divert it away from what we were actually doing, which was changing children's bodies. Over 2017 and 18, 10 members of staff take their concerns to adult psychiatrist Dr. David Bell. He reports them to the leadership of the Tavistock, but the resulting review is a whitewash and doesn't accurately reflect the serious concerns that were relayed. So at that point, some clinicians turned to the media. By the autumn of 2020, my colleague Deb Cohen and I had made 4 films for BBC Newsnight on different aspects of care provided to gender-distressed children. And then 3 things combine to really help precipitate the end of GIDS. Firstly, there's the judicial review, brought first by Sue Evans, taken over by Kira Bell, who was one of GIDS's former patients, who regrets her transition. Ultimately, the case that lost on appeal, but what it did do is show the world how GIDS knew next to nothing about its patients and had seemingly failed to collect any meaningful data on them. Then we had the CQC inspection prompted by one of our reports, which, in an utterly damning report, rated the service inadequate. And then we had the NICE evidence reviews, which rated the quality of evidence very low. Responsibility for letting down thousands of children extends widely. The leadership of GIDS obviously must take responsibility, as should the leadership of the Tavistock, but so too should NHS England, who abdicated their responsibility for overseeing the service. Why did it allow routine prescribing of puberty blockers to happen without seeing any data? Why didn't it insist that GIDS follow up its patients? And we've got to go wider too, to the CAM services who palmed off these children onto GIDS, knowing in some cases that gender really wasn't the major difficulty. And to all the others who didn't speak out, those who were told what was going on, who saw what was going on and did nothing. So the CQC for many years, the government, the MPs on that select committee, the media, and no one really has been held to account. I don't wish to monster individuals, I really don't. The failure is collective, but just try to think of any other scenario where a service is judged to be failing, inadequate, unsafe even, and the leader of that service or business is not made to step down as a result. Or an independent court finding that a boss had instructed staff not to seek safeguarding advice, that a medical director had bullied a member of staff, and neither of them resigning as a consequence. there have been no major consequences for anyone involved. The clinical lead for GIDS, who prescribed those blockers based on poor assessments and continued to do so when data showed them to be of little benefit, was invited to Parliament just a few weeks ago to give his expert opinion on how to conduct a medical trial. What were these politicians thinking? With the news that the planned puberty blocker trial will only follow up children for 2 years, I do fear that we have learned little and are at risk of repeating some of these mistakes again. On that happy note, I hand over to Sally.
I got my slides. Well, thank you, Hannah. I think that was a really sobering overview of kind of why we needed the CAS report. So what I was going to do is talk about really responses to the CAS review. So hopefully it will. Here it comes. Here we go. Yeah, there we go. And I'm going to. There've been really quite a wide range of responses if you're on social media or if you read the newspaper or even listen to BBC Radio. So you will hear lots and lots of different responses to the CAS review. And I really just wanted to go through, rather than rebuffing or agreeing with the responses that we've seen, giving you the tools so that you can work out what's being said and why it's being said and who is saying it. Because if you've got those tools, then you can kind of make sense of it. And I really feel for particularly the parents of people who have children with gender distress, because they will read the CAS review, they will get very worried about what may be on offer, and then they will read criticisms and they will maybe not know what's going on. So hopefully I'm going to leave you with the tools so that you can work out when you read a criticism of the CAS review or you read praise for the CAS review, you can work out really what's happening. So I'm going to give you two pyramids. These are the two things that you really need to know about. The first thing is the evidence pyramid that we use in medicine. So right at the very bottom of that pyramid, this is the lowest level of evidence that you can get, is expert consensus. So what experts generally think we should be doing with our patients. That's right at the very bottom of the pyramid. And there is a good reason for that, because that expert consensus is based on a whole range of psychological biases that we all are subject to, and doctors are no exception to that. So there are all sorts of reasons why people may develop a consensus, and once that consensus is there, it's very difficult to change it. So expert consensus is right at the very bottom. And expert consensus in medicine is often wrong. This isn't a historical thing. We get it wrong time and time and time again. So if we think about stomach ulcers, certainly in my lifetime, once upon a time it was due to stress and spicy food, and it was treated very much with acid suppressing treatments. And then people realised, actually, it's bacteria. It's bacteria that are causing these stomach ulcers. And that's completely revolutionised the way that we now treat stomach ulcers. That was in the 1980s. More worrying, anyone who's had a baby recently would know that you put your baby on its back to sleep, because that reduces the risk of cot death. Well, from 1970 to 1990, the expert consensus was to put your baby on its front to sleep. And actually the evidence was there that was a risk factor for cot death. So the evidence was there, but the expert consensus went against that evidence. And there's a paper by the group in Oxford that worked out that 50,000 babies' lives could have been saved if we went with not the expert consensus, but the evidence. Okay, so there's lots of these examples. You find them in oncology, you find them in neonatal care, you find them in cardiology. Expert consensus is often wrong. And that's why we have this evidence pyramid. So we don't just rely on what the doctors think. We've got these steps of, well, what's really true? And all of these steps up the pyramid, randomized controlled trials and meta-analysis and things like that, they will all help us understand what the evidence says and overcome the biases that we use, all of us are subject to. It's not that doctors are being negligent, everybody's subject to these biases. So this is why we have an evidence pyramid. Okay. The CAS review sits right at the top of that evidence pyramid. So it's looking at, we heard from Hannah how it was made up. So it's made up of literature reviews. It had some research. Well, they tried to get some research. They tried to get the data from the adult clinics. They weren't allowed to get it. And I think actually that's one of the biggest scandals of the CAS report. I think, it's something that's kind of, there was a little bit of fuss at the time, but actually NHS services did not give CAS the data she needed. And that's a really important thing. And it's coming back now because we're thinking about a puberty blocker trial where we don't have that data. So that's a really important aspect. We had the data link. She also did qualitative reviews. She also did surveys. So this sits right at the top of it pulls together absolutely everything, even better than a single meta-analysis. It's right at the top. So you would think when it comes out, everyone would think, okay, this is the state of the art, this is what we know. And this was her conclusion. Basically, she demonstrated, when she pulled it all together, integrated it all, demonstrated the poor quality of published studies, meaning there was not a reliable evidence base upon which to make clinical decisions. And that's the main thing you need to keep in mind. So when you are looking at criticisms of the CAS review, every criticism that you read, think of this. Say, is it giving me reliable evidence on which to make clinical decisions? Because actually, that's all you need to be thinking about. Any criticism that you see, is it addressing this? Because if it's not really a very valid criticism. So let's just have a look at some of the critical responses that the CAS review got. You can look at social media and activist groups, and extraordinarily, within, I would say, probably 28 seconds of the CAS review being published, they had immense critiques of what they thought about it. And then you've got individual clinicians, and particularly clinicians who work in the gender services. They've got their own opinions, and they've put those out on social media. And then we've got the opinions of medical associations, and this is where, particularly if you're not following this, you may sit up and take notice and think, well, hang on, the BMA aren't happy with this. Hang on, some of the other WPATH aren't happy with this, or something like that. So for associations, you've also got some peer-reviewed commentaries in some very well-respected medical journals. So again, it might give people pause to think, well, maybe CAS got something wrong. So we're just going to look at some of those criticisms. First of all, some of them just don't like the conclusions. So if you don't like the conclusions for something, you are absolutely within your rights to not like the conclusions, but that's not really a valid criticism of something. So you will particularly see this where the conclusions were a threat to somebody's personal worldview. And that you see a lot of that on social media. And then really they have very minimal engagement with the review. So they make stuff up. They create an acceptable version of events for themselves and the group. And then you just put that on repeat. You just keep saying the same thing until the made up stuff becomes a well-known fact. And you will see this if you look at, particularly if you look at X. And these are the sorts of things that you will see just repeated over and over. So Cash ignored and rejected all the positive research studies that somehow she just picked the negative ones. Up to 90% of studies were excluded. She didn't include trans people in the consultation. She was holding gender-affirming care to impossible and unrealistic standards. And she insisted on a double-blind randomised control study. So you will see this all over social media, and that's the level of criticism. So these things just aren't true. So that people have just made something up, and that's just not true. You've got people who don't like the conclusions, but you've also got people who don't agree with the conclusions and think that they have some evidence for that. So these are the more interesting criticisms that we need to engage with. Nothing is perfect, and I think Hilary herself would say it's not perfect, but it is the best we've got, probably. But if you don't agree with the conclusions, then let's look at the evidence for disagreeing with that key conclusion that we don't have a firm evidence base. So this is your second pyramid, and this is really, really important. So there's something called Graham's hierarchy of disagreement. He was actually a dentist who came up with this, and he he put these in again. You've got a kind of thing at the bottom, the lowest level of disagreement, right the way up to the top. So right at the bottom, you've got name calling. So you just call somebody a name. It's the lowest form of disagreement. You just insult the person who said something you don't like. In this arena, most often it's you're a bigot. You're just a bigot. That's why you're saying this. Well, that's not why you say. They just say you're a bigot. And then we move on to the ad hominem attacks, where you attack the character of somebody who's saying something that you don't like. And most often you'll see you're saying that because you're an extreme right-wing transphobe. So that's the sort of thing that you will see quite often. And that's the limit of the engagement. So they don't engage with the arguments. They are just attacking the people who say it. And I think all of us on this platform have probably been subject to that kind of thing. And then you'll get people responding to the tone of the way that an argument has been put. So this is an example, actually from a peer-reviewed article. The language used in the review implies a bias against transgender individuals, reinforcing harmful narratives. So it's the way you've said something. It may be the way you've said something, it may be where you've said something, if you've published in the Telegraph or something like that. So it's responding to the tone of something. And then you've got contradiction, just simply stating, that's not true. That's just not true. Or just puberty blockers are safe and reversible without saying, giving you the evidence for that. So just a flat denial of what's been said. All the way, so those four steps in the pyramid don't really provide any basis for disagreeing with somebody. They're expressing that you don't like the conclusions, but they're not actually addressing the evidence. So we're then going to move on to the top levels. So counter-argument, this is where you present an opposing argument, but you're not really addressing the original claim. So you might say, and we will hear this a lot, well, puberty blockers have been used for years without concerns in children with potential precocious puberty. Well, that's not the argument. The argument isn't about giving puberty blockers to those children. Or you can go to refutation, which is really what we're looking for. If you're going to disagree with something, this is the level that you need. So you find a flaw in the person's argument and you explain why it's correct and you use evidence. So this is here we will be looking for somebody saying, well, Cass is wrong because she's used outdated research and here's a more recent study that's good quality that provides an evidence base. So that's what we really, really want. And ideally, we want somebody to refute the central point. So the central point is the highest, most effective arguments against something. What did Cass really say in this review? She said the evidence wasn't good enough. So if you can refute that central point and come back and say, yes, it is, here's the really, really good quality study, and here's the outcomes, and we followed these children for 15 years, and we know who's going to benefit, and we know who doesn't, that would contradict what Cass has said. It would be fair to say there aren't any arguments. Nobody, not from social media right the way up to the published reviews in peer-reviewed journals, nobody has refuted the central point, not one person. Okay, so let's just have a look at some of the examples. So this was put out on the day that, this is a psychologist, put this out on social media the day that the Cass review came out. Bad news for our trans youth this morning, but let's be honest, we knew it was coming. In 2021-22, I reviewed the WPATH guidelines, and the conclusions are out of step. The conclusions of Cass are out of step with better quality, more comprehensive reviews, and out of step with approaches in other countries. Well, yes, they were out of step because Cass is the most comprehensive review of this evidence that we've had. The reason Cass didn't find it is because she wasn't using clinical consensus. She was right at the top of the pyramid, not pulling things from the bottom. So that's one psychologist. And then this is a more recent one. The biased and flawed Cass review is not respectful of trans youth. There are multiple critiques from within the trans community. Other countries have completed much more in-depth reviews and have come to very different conclusions. be aware of transphobic gender critical clinicians. So you've got some name calling in there, you've got some ad hominem attacks, you've got some things that are just completely made up. And effectively what this person has done is just put lived experience right at the top of that pyramid. And that's not, and it's about as sophisticated as that as well in terms of an argument. When we come to looking at the critiques in the medical literature, we need to be thinking a little bit more. I mean, well, some of them are still ad hominem attacks, and some of them there's still even some name calling as well. Unfortunately, so this is an article that came. Okay, yeah, I've got about 2 minutes left. So the New England Journal of Medicine published a response, really from a legal perspective, arguing that somehow receiving medical treatment was a rights issue. And then you've got something called the Yale response. It's written by some people who work at Yale, but it's never been peer reviewed. It's been put up onto the website. It's been changed it changes every now and then if you go back and have a look at it. But this Yale response has started to be quoted within the literature as if it is a peer-reviewed thing. So, and this is how these arguments kind of get into some of the medical literature, is that they become circular and they all just start with kind of quoting each other, and you get this circular thing. There's some really nice responses to these critiques, so critiquing the critiques. And if you scan those QR codes, you can read these. Are really nice. Just they take that these critiques of the critiques actually use the disagreement pyramid properly, and they go through and they engage with the arguments that have been given, and then they provide responses that are based on evidence. And they said, well, this isn't true because look, we've got this and we've got this. So they're really quite satisfying to read. So I would recommend that you do that. But one of the key things that came from them is the responses identify an extraordinarily large number of errors, just errors of fact, really clear. They just it's not true what they're saying in peer-reviewed literature, which is very poor. And some of the quality of the criticisms is on a par with the quality of the studies she reviewed, which isn't surprising because it's coming from the same people who conducted some of those studies. Okay, so just for the record, just so that this is out there, you will see this a lot, that the review holds gender medicine to a higher standard than other paediatric medicine or requires a randomized controlled trial. That is not true. The very low quality of evidence in gender medicine does not stem from a lack of randomized controlled trials, but from poor study design, just across the board, inappropriate comparison groups, high attrition rates, and inadequate follow-up. This is what makes the literature poor. And sometimes, and particularly in my field, just completely non-existent studies, so that nobody has looked at this. So there's that. And then this one, the recommendations of the CAS review are transphobic and discriminatory because children with central precocious puberty are prescribed puberty blockers and no one worries about the harmful impacts on them. Well, yes, we do worry about the impacts of them on them. We always worry about, all medications have the potential to harm people. But puberty blockers are used to treat an abnormal physiological process in children with central precocious puberty, and they're used to prevent a normal developmental physiological process in children with gender-related distress. And medical treatments are based on your condition. They're not based on your identity. Yeah. Okay, so when you are looking at any criticism, and if you're out there and you have children who are distressed and you don't know what to do and you don't know what's right, you don't know whether to look at CAS or to look at some of the other people who say, look, we are the experts because we've been treating these kids for decades. This is the key thing that you need to remember. So is the person presenting a firm evidence base based on high quality studies that allow the clinicians to make a decision? That's all you need to have in mind. And is the criticism that you are reading actually counteracting that and saying, look, here is that evidence? If it's not, then it's not a valid criticism. And having looked, I cannot find any basis for anyone presenting those things. So.
Great. Thank you so much, Sally. That was very comprehensive. Great.
Thank you for the invite, and thank you both to Hannah and Sally. So I'm quite excited that I think we have actually moved on in order for us to be able to even talk about psychotherapy and therapeutics. I mean, 10, 12 years ago, if we had been asked to come here and talk about gender, I don't think we would have been allowed to even talk about psychotherapy, because people really conflate what we mean by psychotherapy. So today, I'm going to talk about psychotherapy in the post-CAS review era, and I'm going to focus a little bit on the what, the how, and for whom this is relevant. So after April 2024, looking at the CAS review and thinking about it critically, of course, there have been challenges and opportunities in the NHS for the care of gender-related youth with gender-related distress. So rightly so, up to a point, the main focus has been on medical interventions and the ban of medical interventions, specifically the hormone blocking treatment. But very few people actually have taken the time to think about what is on offer when we're not offering hormone blocking treatment. What is on offer? What can we offer to young people and families who are, some of them indeed, very distressed with their gender? So one thing many of us really agree on is the fact that over the years, we have been working with young people who are highly distressed in terms of their developing bodies and gender. So that's a real thing. But we haven't really taken the time to think about how best to support them. So very few people have published on psychotherapeutic interventions for gender-related distress, and even fewer people after 2009, which is about the time when the new leadership of GIDS came into effect. And I guess connecting with my experience there, I know that some of the senior people there, not all of them, but some of them did not believe that psychotherapeutic interventions could be successful in alleviating gender-related distress and improving psychosocial functioning, which is at the core of what many of us are trying to achieve. However, there was never any evidence on this. I mean, when I looked into the evidence, there was nothing there. So we do know from clinical practice and practice-based evidence that some psychotherapeutic attempts working with young people who are highly distressed with their gender and their parents and carers have been successful in alleviating distress, improving their psychosocial functioning, and helping them thrive by targeting co-caring difficulties and thinking about it holistically. We know that there's a highly polarized debate when it comes to psychotherapy. There's ongoing debates about conversion therapy, and any attempts to support young people psychotherapeutically has been labeled as conversion therapy, which we know is not the case. However, there's some context in this. We know that in the past, some psychotherapeutic schools and approaches have been quite harmful when it comes to individuals who identified as lesbian, gay, or bisexuals. There's also some tiny evidence that perhaps some of these approaches had also been practiced with kids who had shown signs of gender nonconformity, so not adhering to whatever society is asking us to adhere in terms of gender stereotypes. But again, we don't have any evidence that, especially in the past 20 or 20-something years, that conversion or aversion practices have taken place in the NHS when it comes to young people with gender-related distress. So today, I just want to focus on 4 points coming out, 4 recommendations from the CAS review, because I think it's so relevant to what we're discussing today. One is related to psychotherapy. Recommendation 3, standard evidence-based psychological and psychopharmacological treatment approaches should be used to support the management of the associated distress and co-caring conditions. This should include support to parents and carers and siblings as appropriate. Recommendation 14, which I connect to leadership and systemic changes needed, that NHS England, through a workforce training and education function, must ensure requirements for this service area are built into overall workforce planning for adolescent services. Recommendation number 25 for detransitioners, which we know they do exist because we work with them. NHS England should ensure there is provision for people considering detransition, recognizing that they may not wish to re-engage with the services where they had gotten support from. And recommendation 31, which I connect to leadership and responsibility and accountability. Professional bodies must come together to provide leadership and guidance to the clinical management of this population, taking account of the findings of this report. So when we talk about psychotherapeutic approaches for gender-related distress, it's not a new thing. However, very little has been published on this. But when I did a scoping kind of review, I saw that there have been different models over the years. Some of them have been more assessment heavy, and a few of them have been more psychotherapeutically oriented. So the Canadian one, they would argue that it was more of an assessment one, even though I would argue that it has a psychological and psychotherapeutic underpinning. We know that the Dutch model, at some point, they kind of abandoned or they neglected thinking about the role of psychotherapy, but it was there initially. And the watchful waiting one, I've put it there because many people actually get really confused. They think that this has always been the practice in GIDS. Domenico Di Ceye, who wrote about watchful waiting in a more psychoanalytic kind of approach, it was mainly focused for prepubescent kids. So this new cohort of adolescent onset gender-related distress, we don't have much written about in terms of how to support them psychologically and psychotherapeutically. And I'm not going to even talk about the gender affirmative model or even GIDS from 2009 onwards, because this is when really the psychotherapeutic underpinning and the psychotherapeutic intervention was completely abandoned for no reason, but it was abandoned. And I've included exploratory approaches because more recently there has been a re-emergence of psychoanalytically focused, systemically focused, and CBT focused approaches. So this is just my slide. I'm not saying it's a conclusive one. However, if you are interested in theory and practice links, which I think is extremely relevant for the new services, it's also important to know the theoretical modality and underpinning of each approach. So why this is important, and why do I keep saying that exploration and psychotherapy is important before affirmation, not alongside, not after that, but before we actually clinically affirm someone. We do have strong evidence that psychotherapy does work with adolescents with embodied distress. The National Institute of Health and Care Excellence recommends systemic and family psychotherapy for young people with eating disorders, which, as we know, can be a potentially life-threatening illness, and especially for anorexia nervosa. The first-line intervention is systemic and family psychotherapy. There's really good evidence that it helps with 60 to 70% of the young people who are suffering from that. With body dysmorphic disorder, we know that quite often a combination of SSRIs and CBT does work for the majority of the young people who present. So what I'm trying to say is that this is not rocket science. We do have conditions and clinical issues in adolescents where we know that psychotherapeutic approaches, which are evidence-informed, can have a really good success rate. Different therapeutic approaches, we know that they have different evidence. We don't have any evidence on what really works with gender. This is not because nothing works, it's because no one has really looked into this. But we know that irrespectively of what model of therapy someone follows, the most important thing is the relationship between the therapist and the patient and the parents or carers. And I think that's a really important point, because in most of the cases where therapy has failed to be helpful with gender-related distressed youth, it's because they've come in, they have been told that any psychotherapy is a form of conversion therapy and they cannot really connect with us. And sometimes they really try, but they can't connect with us. So we really need to take into account what happens outside the therapy room and how this informs young people and families presenting for support. And I really believe into the process of democratizing the therapeutic encounter. We really need to know what we're offering young people and families. They need to know what is on offer in order for them to be able to consent. Unless they consent, we can't actually have therapy. And this is also a note to parents who often bring kids to us who do not want to have therapy. It doesn't really work. They need to consent to this. And this is just thinking a little bit about context, that any therapeutic encounter, irrespectively of what is the modality and the theoretical underpinning, needs to work with people in a developmental way. We work in a very different way with a 5-year-old birth-registered female who thinks is a boy, and in a very different way with a 16 and 17-year-old. Identity exploration, whatever this means for different people, needs to be at the core of any such approach. And also we need to target co-caring conditions and embodied distress, which often many clinicians overlook. So I do believe that we need to systematize the psychotherapeutic process, and this is important for the new gender hubs. That's my personal view, because actually consistency is important for the services culture and cohesion. Otherwise, we run the risk of going back to GIDS, where different clinicians were practicing as they wanted, but without any consistency. For families and young people to know what is on offer from the time of the assessment. I think any assessment needs to be a therapeutic assessment, and by the end of it, to know what are the therapeutic options. Currently, I don't know what is on offer. We need to think about research and training, so how we train new workforce and how we train trainees who are on training, but also I think we need different models. At this stage, I can't tell you whether a psychoanalytic approach works for whom a psychoanalytic approach might work, and for whom a family or systemic approach might work, and for whom a CBT approach might work. But in order to be able to compare these approaches, we need to develop the models initially, and to also think about the fidelity to the model. So again, I think we need more clinicians who are interested in developing different approaches, and then we do need collaboration with universities and NHS England in order to test this. This is just a schema of how I would like to describe the way I work. When I reviewed some recorded sessions with consent from families that I had received, I saw that loosely kind of defined, we have the initial phases where we focus on creating safety and engagement. That's not new for therapists, of course, and for different models of therapy. That then we get into thinking about the assessment and thinking about co-caring difficulties and any distress that might be there. You can't really do this. You can't really assess someone or do a co-assessment without connecting with them first. And then we get into more thinking about the identity narratives and the experiences in a developmental way. And we take it for granted that there will be different outcomes for different young people. And psychoeducation, what we know about brain development, maturation, and all of that needs to be at the core of any particular kind of phase of treatment. 5 minutes. Leadership and systems. I think we need to embed training at all levels of higher education, and this is so important. There was a recent example last week from a very large UK university where I've been teaching for more than 10 years, and there was a new director of a specific, just one of the programs where I happened to teach, who emailed me and said, brilliant, you have really good feedback from students, but we do need to review your training. And when I asked why, they said we also need to offer training to trainees, clinical psychology trainees, who do not align with CAS and do not want to align with CAS in their clinical practice. So I think this brings up so many new issues in terms of how do we make sure that especially NHS England funded clinical trainings, they do align with CAS, which is, as I understand, the current recommendation from NHS England. So again, thinking about management, but also leadership at different systems. The transitioners, we know that there should have been provision for them. Unfortunately, currently there's none in the UK. The transitioners do exist, as trans people also exist. However, currently the only service, we have a small service together with my colleague Dr. Kirsty Entwistle called the Trans Foundation, and we often have requests from people who cannot afford private therapy. They're looking for pro bono support, but also some of them, they have complex needs that connect with both physical and mental health. So again, thinking about when the new services for the transitioner will be launched is so relevant to therapy. And then leadership and responsibilities and accountabilities. I think that we run the risk of having so many missed opportunities. I can speak about some of the professional organizations I've been involved with. We have offered with Dr. Anna Hutchinson free training for members of organizations, and they have not taken this up. So there's also a question of how do we embed training and knowledge at different levels and different professional organizations, and why some are still resistant to adopting CAS. So parting thoughts, it is the right time to be thinking about what psychotherapy entails for youth with GRD. NHS England and relevant stakeholders should invest in the process. They haven't, I'm not saying about NHS England, but hasn't been so much focus on what is the psychotherapeutic offering in terms of youth with GRD. We do need to think about embedding thinking and practice across levels. Different outcomes will be there. We know this for sure. And unless we develop and evaluate different psychotherapeutic approaches, we will never know what works and for whom. So I'm going to leave you with this quote from Michael White, who has said that the most powerful therapeutic process I know is to contribute to reach story development. And I do feel that some of the youth we're working with, they do need time and space to enrich the narratives that are available to them about what's happening to them and their bodies. Thank you.
but I'm here to cheer you up by talking about culture. So we talked a lot about what we don't know, and you know, a very difficult situation for all of us who've been involved in this area of clinical work. But the fact of the matter is, post-CAS, before the new gender hubs are developed and before new models of working are developed, young people are seeking help right now, today, in clinical rooms across the country. And most of these young people won't be seen in the specialist gender hubs. So I wanted to spend a bit of time thinking about how we could use CAS to help those clinicians and what they might be doing with these young people. Just a quick point. Sally spoke about how some have argued that the methodology of CAS is controversial from a clinical level. It's also been argued that the recommendations are controversial. Have a look at those recommendations. I think they're pretty vanilla. I think they're identical to the recommendations that are made for all young people in distress, really. And CAS actually recommends a biopsychosocial approach, as is recommended for all young people with distress. Can we do it? Well, Anastasis has talked a bit about, well, we do already have lots of knowledge that we can apply to this group. We've got knowledge about biology, we've got knowledge about neurodevelopment, we've got knowledge, as he said, about working with the body, and how young people, adults, recruit our bodies to express distress. And there's lots of models for working with this. Hundreds of years of literature, so can we do it? Yes. Bio, we've got that. Psycho. Psychologists, psychotherapists work with identity all the time. It's our bread and butter. There's hundreds of years of philosophy and more recently clinical writing on this and an evidence base, many evidence bases for many different models. We know a lot about identities and how they develop. We know that no one is born with a fully functioning social identity because all identities are constructed, aren't they, between the individual and the society within which they live. And our adolescence, of course, this is, everybody understands, Aristotle understood that, and I'm sure cavemen understood, that adolescence is a time of identity development where we see people trying on different identities, and that's a normal process. Young people looking to the world around them, identifying with parts of that world, taking it into their own identity to prepare them to individuate from their families and become adults. So identities are functional, aren't they? They help us through life. Working with uncertainty, as you've heard tonight, there's uncertainty everywhere in the gender field. Psychologists, psychotherapists, psychiatrists, that's what we do. Uncertainty can be profoundly distressing. But too much certainty can sometimes be a sign of poor mental health. It can be indicative of a psychological defense or a rigid way of thinking. And actually, flexible thinking, cognitive flexibility, is a sign of good mental health. So as psychotherapists, we actually not only work with uncertainty, but value sometimes, or even encourage uncertainty. And just to remind us that that's very different from medicine. They have a different evidentiary requirement for prescribing medication. And I think that's where one of the issues is in this field, that you've got psychology and medicine working together with different needs when it comes to certainty and different relationships with it. So can we do it? Yep. Biopsychosocial, we all understand that we live in families, in groups, in society. And I'll do those. And Dr. Cass spent a whole chapter talking about wider society and culture. And in that chapter, she invited us to think about the young people who grew up in the 2000s, who make up that big group of the GIDS referral data. And specifically, she invited us to think about what was it like to be the first generation that grew up online and were potentially hurt by what they witnessed online. She pointed out that younger generations have different beliefs about sex and gender to us older people. And she also said there's something going on with mental health. So can we do it? Yes, we can. We often use transferable skills in therapy. We draw from different areas. That's normal. And working in a transdiagnostic way is something we do all the time. And when I say transdiagnostic, I have to caveat this now. I'm talking trans across from, we work across diagnoses with a set of clinical tools. So this isn't a crazy idea, and this isn't exceptionalism to suggest that we've got tools that we can use with these young people now. So why isn't it easy? Anastasis and I have trained lots of our colleagues and professionals in working with this group of young people. And they know they've got the skills too. So what's getting in the way? And the feedback is, well, what we've heard about tonight, the debates about who these young people are and how best to help them are overwhelming, and they're toxic and they're hostile. There is a sense that the kids know more than we do about it, and people are scared of getting it wrong. And that's understandable. They're scared of getting it wrong for the kids, but they're scared of getting it wrong and being punished socially as well. So the stakes are very high. So culture is getting in the way, not ability to help. So I suggest that what we all need to do, we've got the skills, what actually needs to happen is a really broad increase in cultural competence. So what is it? So ChatGPT says cultural competence is the ability to understand and effectively engage with people from a diverse range of backgrounds. And of course, in psychology and psychotherapy, that is absolutely vital for ethical and effective care. It helps professionals understand how culture affects beliefs, behaviours and mental health. So it's an absolute core tenet of the work that we do. But thinking about things broadly, intersectionality is a part of being culturally competent. So yes, we need to understand the groups within which people are embedded to have a general sense of what might be going on for them. But we don't want to form our whole understanding on one aspect of someone's identity, their skin colour, their faith or their gender identity. We have to think about how one aspect different aspects of an identity all interrelate, and different aspects of a lived experience. And we know in the gender-distressed young people in this cohort, we're not just seeing young people with gender-related distress. It's very rare to see somebody where that is the only thing that they're coming to therapy with. There is a relationship between gender-related distress, mental health, and LGBT identities and or same-sex attraction, because they are not always the same thing. So to be culturally competent for working with these young people, I argue you need to be culturally competent for working with mental health in young people generally, and also in issues related to LGBT or same-sex attraction. So very quickly, let's look at mental health. How do we become culturally competent? So I'm not talking about the skills, I'm talking about thinking about what's going on a broader level. This is a slide from Jonathan Haidt's The Anxious Generation, the bane of every parent WhatsApp group, I think, at the moment. And it's this American data, but you don't have to look at the details. We're talking about anxiety here, but this is just showing that over time, anxiety overall seems to have gone up, but much more so in our young generation, the ones that Dr. Cass was talking about in the review. And there's also, so there's a cohort effect, yeah? More people, younger people are expressing issues with their mental health, but there's also a sex effect. So we are seeing our girls, birth-registered girls, seeking help with their mental health at a much greater level than our boys. And people are asking questions, what is going on? We've all seen the media reports about the mental health crisis in young people, and other people are digging deeper and thinking about, is there a mental health crisis? Have we got a profoundly sad bunch of young people, sadder than any other generation? Or is there something going on culturally about how we've all become so aware of mental health and mental health campaigns, and as a result, are young people either pathologizing themselves more easily? Are they more comfortable coming out? The likelihood it's a mix, that we are both identifying genuine difficulties better, so we are helping people better, but there might also be something that's happening where people are recruiting mental health terminology from society and using it more in their describing their experiences. And furthermore, it seems that some of our adolescents are looking into society, seeing that mental health is salient, and as adolescents do, recruiting from society and building identities around diagnoses. That's something we're seeing. So we don't know exactly what's going on. Let's look at LGBT and T identities. So this is from a very recent Gallup poll in the States, more American data, I'm sorry. But what you can see is that over a decade, the number of people identifying as LGBT has doubled. That's in the whole adult cohort. And once again, there is a cohort effect. So 3% of the baby boomers are currently identifying as LGBT versus 23%, nearly 1 in 4 of Generation Z. And if you dig down into that data, there is also a sex effect. So the majority of the younger generation identifying as LGBT are female and are identifying as bisexual. So we've all seen this. It's burnt into our retinas. You saw the graph earlier from Hannah. So look, all these graphs are looking somewhat similar over the same time span, and we're seeing both a sex and a cohort effect. And we don't know what's going on. We've got lots of hypotheses. We don't know about these identities over time. Will they persist or desist, to borrow a phrase from gender? And could it be that we're not experiencing a mental health crisis, but we're experiencing some sort of profound disruption in identity development, some of which might be beneficial and some of which might be less so? Okay, so using all of this, how can we apply it to working with gender distressed youth? We've got the skills. 3 minutes, okay, we can do this. Okay, so to be culturally competent, do we listen to and honour people with lived experience and trans communities? Yes, of course we do. That's our job. We need to listen to the stories, and we are hearing the stories. And within the trans communities, there are people who are desperately distressed at what they see as a cruel society taking away life-saving treatments, and we have to honour that. But equally, whenever we work with communities, we have to look at where a community's ethics might be in conflict with professional ethics, and that's where it gets spicy and tricky. And as well as those well-known narratives about what it is to be trans or to have gender distress, we need to listen on multiple levels. And this is where the rich stories are coming in culturally. Anastasis and I are hearing them daily, weekly. And there's stories coming from not just the girls. We've heard a lot about the girls in the media, but about young men who are desperately trying to find identities where they can communicate to the world that they too are vulnerable and need to be viewed as beautiful. So there's a lot. If we can go below the dominant narratives to the more subjugated narratives, there's a lot to learn there. And there's still quite a lot of homophobia that these young people are experiencing. So at that level, the lower level, listening to the deeper stories, maybe our society isn't as progressive as we'd like. I think to work in this area, you have to understand all of the debates, as you said, Anastasis, because you have to position yourself somewhere. Ideally, as psychotherapists, we should position ourselves above the debates and be able to move them. It's difficult in this arena, but at the very least, we need to own the position we're working with and be able to explain it to the young people so that they can consent to work with us. Talked about that. Dr. Cass says that it's also our duty to address misinformation, and I think that's absolutely the case because we have a duty of candour when working with our young people. So we need to know the whole story and all the debates from every angle. To summarise, we are working in a field where there are scared young people and scared adults, and that is a bit of a recipe for disaster. But fundamentally, it's on us, the adults. The adults are writing the treatment guidelines. The adults are writing the laws. And one way to feel less scared is to learn more. And we can learn from the young people based on the stories we're hearing in the clinic rooms. I would say that this might be controversial, they may be right that some things still need to be queered. I'm talking about sex stereotypes. And what it means to live as a same-sex attracted person in our society. But Cass reminds us that there are some things that we shouldn't queer, and I don't think we should be queering safeguarding, and we certainly shouldn't be queering evidence-based medicine. So therapy with gender questioning children is both possible and necessary, and Cass has helped us with that. Reading the Cass review can help you become more culturally competent. And I'd also say, as you said really at the start, that the Cass review itself is a product of our culture and a culture moment in itself. Okay, thanks.
Great. Thanks so much, Anna. Is this one working? Can you all hear me? Yep. Okay, great. Brilliant. Well, I think what I'm going to do is I'm just going to put one question to the panel, which was a big question that the CAS review left me with, and then I'm going to come straight to the floor just because we've only got about 25 minutes left for questions. So I want to make sure that everyone with questions in the audience gets them in. So I guess for me, reading the CAS review as a layperson, the big conundrum it left me with was, on the one hand, Hilary Cass was saying, we can't predict which children who are gender questioning are going to have lasting trans identities, and which children for whom this identity is going to resolve itself and go away. So I guess my question, I don't know which of the four of you wants to tackle it, but my question is, if we can't predict, and if there are no diagnostic criteria, which there don't appear to be for lasting trans identities, how is it ever ethical to put a young person on a medical pathway, a life-altering medical pathway, even as part of a clinical trial? That was a big question. I liked every other part of the CAS review, but I was like, on that one, you fudged it. That's what I felt. So who wants to answer that? Yeah, it's got to be one of you three.
It's a tricky one. I think it's a really thorny issue. I mean, I've been equally surprised sometimes working with young people who I was almost certain, and that's a really bad thing as a clinician to be certain, that they would be embarking on medical interventions because they were actively requesting or even demanding it, and then they changed their mind. And equally, I've worked psychotherapeutically with people who I thought, actually, there's no distress here, they're doing better, they will not start on hormonal interventions, and they did. All I'm trying to say is that, yeah, after more than 12 years working in the field of gender, I cannot predict. So I'm really curious to see what the inclusion and exclusion criteria will be. I think it's a really difficult task, but I hope that we will have more visibility over what are the inclusion and exclusion criteria. I wouldn't want to be part of that because I think it's a really, really tough call. But I suspect that there will be some inclusion exclusion criteria that will make sense. But for instance, the more kind of the questionnaires that we used to use with this cohort have shown no correlation between what they produce when we give the questionnaires and the later outcomes. So again, there's so much complexity there, and how it intersects with gender nonconformity, how it intersects with other aspects of identity. So I'm not sure. But we do know from birth cohort studies in the UK that young people, prepubescent kids with high gender nonconformity, really strong gender nonconformity, as adults, this connects more with lesbian, gay, or bisexual identity. So again, it's a really difficult task that they have.
Yeah, I mean, I guess, maybe Anna, this is for you. I'm interested in, I mean, how do you decide which kids to give the drugs to? Like, I just, yeah.
Well, I wouldn't make that decision. I'm quite clear that I wouldn't ever refer anyone for a medical pathway at the moment because, personally, the evidence base isn't there. You know, and the CAS review says that there's no predictive validity to the diagnosis. So even if you've got the diagnosis, we just don't know either way. And to me, that feels like a gamble. You know, and there's a difference between gambling with offering somebody CBT or not and a 3-stage pathway, you know, leading to, surgery in adulthood. And for me, that's a gamble I'm not prepared to take.
Right, thank you. I'm going to open the questions to the floor now. So can I see raised hands? Excellent. So we'll go first to the lady in the purple and the red there. Sorry, not you. I'll come back to you later. Are we going to have mic circulated? Okay, great. I'll take 3 at a time, by the way.
Hi, thank you. Is this working?
Yeah, I think it is, yeah.
Is this working? Okay.
Yeah.
So I've come along from Scene in Health. I'm also a member of CanSG, but if anyone, we're actually a staff network for the NHS based on the protected characteristic of sex. So if anyone who does work in the NHS, please come and join us. I mean, a couple of things. One is regarding the mental health in teenage girls. I did see this with my own daughter, and she was encouraged into her anxiety by a school teacher. And that eventually led her to cutting herself. And actually, the lockdown saved her from the school and this particular teacher. But coming back to the trans issue, I'm a GP, and I'm particularly bothered about the young adults that I see. I'm in a university town, and there's lots of young students who have trans identities, and to some extent I kind of see that maybe we're winning the war from the children's point of view, but once they turn 18 they can go on to these damaging wrong sex hormones. And it's terribly distressing when I see these young people that come and see me, and I just don't know what to do. You know, I say to them, can I help you? Are you okay? Can I offer you some support? And they'll say, no, I'm fine. And I'm just very sad for them.
Great,
I
thank you.
Like to comment.
Thank you. I have a couple more questions. Lady at the back there, if you could keep them brief, that would be great, because we're so short on time. Thank you. Oh, no, it's fine. It was a great comment, but...
Yeah, so Hannah mentioned at the start that the Dutch protocol, when it was adapted by GIDS, was used on children that it wasn't appropriate for. And Anastasis, you spoke about a carefully selected cohort with the Dutch cohort. So I just wonder if we could go through the panel. I think Anna's kind of answered this question. Do you think that there are any children who need to take puberty blockers to block their natural, healthy puberty because they've got gender-related distress? Just yes or no would be great.
Okay, great. Thank you. And one more question. We'll come back to you. In the purple jacket.
All right. Yeah, hi, I'm from Thoughtful Therapist, and I've got two quick things. In the Northwest, we've got a young person service, and I know people are phoning them and very concerned, and they are recommending Gender GP to get the hormones. So we know this is actually going on. And the other thing is, when it comes back to therapy, our professional organisations are an absolute nightmare. And we're coming back to what Thoughtful Therapists was initially set up to campaign against, which was the MOU, the Memorandum of Understanding, and it's still there, and all the organisations are signed up to it. So we really need to get it shifted so that we can do the kind of work that you're talking about, because people are really frightened. And the ban on conversion therapy is coming back again, and we've already got this within our professional organisations who. That's it.
Thank you.
Not all of the organizations.
Oh, UKCP.
UKCP has opted out.
Yeah, but they
They had a lot of issues.
Great. Okay, let's start with the issue of young people and what happens post-18. Sally, do you want to start off with that?
So in terms of your kind of post-18-year-olds, from a neuropsychological perspective, they are they've got a long way to go before they're fully developed, and particularly when we're thinking about executive functions and the ability to really see kind of grey areas. They tend to still be in very kind of black and white thinking. And so from my perspective in my service, really I don't think of them as being adults until they're about 25, because that's when the brain is kind of in an adult state. So we know, and I mean, that's not just clinically, but we also know that from neuropsychological studies that we've got a lot of brain development to go up until about 25 and beyond, actually. I mean, it's not just that it stops at 25. So I think there is an artificial cutoff at 18. It's just an admin thing. It certainly doesn't have anything to do with where somebody is in terms of their psychological development. And I think, again, it's bringing in what we know about psychological development, what we know about people, and bringing that in to all of our clinical practice. But other people can talk more about the gender aspect.
Yeah, I wonder then, why didn't Cass recommend a service that went up to 25? Was it just because that wasn't her remit?
Can I just make, at the risk of making myself extremely unpopular, I do think, okay, it's an arbitrary cut-off. I say this, I'm not a clinician like you three, but I do think that we allow people to make all kinds of really bad decisions when we reach adulthood. And generally, we do understand that as 18. So I know that I'm probably faced with a wall of people that disagree with me, but I think you really do veer into exceptionalism here. And I think if someone is provided with all the data, I think that's the problem, and it's put into context, then that really is a decision of personal choice. And as long as that is done, which we know currently it's not done very much, then I do see it's problematic to single out this.
I think I would just come back a little bit there. No, so just in terms of, so we're not saying that 18-year-olds can't make decisions, but what we're saying is that they make decisions in a different way to adults. And as a GP or as a clinician, we need to be aware of that when we are talking to them about their options. So you would talk to an 18-year-old, a 20-year-old in a completely different way to the way you talk to a 45-year-old. And it is about presenting all the options, and it is about helping that person see what's available to them and the consequences of that. But you, as a clinician, understanding brain development, you need to be aware where that person is and the sort of help that they need. And it's not exceptionalism. So I would do that with my patients who don't have this issue. So, yeah.
Okay, regardless of brain development, regardless of, cut off, at some point we have to let people make these decisions for themselves. But for informed consent to be possible, they have to be informed and not misinformed. And I think that's the issue clinically at the moment, because you've got different clinicians, different, medics working in different ways. And we've seen historically that people haven't always been given all the information they need to make their decisions. And, the young people that come into our rooms, there's so many dominant stories about how these medicines help and how life-saving they are, and they believe them as they should be able to believe medics and society. So in order for even us to have those debates, we've got to all be well informed, and that includes mainly the NHS at the moment.
Right, I'm going to take another round of questions. Can I see some hands? Gentleman over there.
Yeah, NHS England was mentioned by most of you guys, but I think NHS England is a very big thing. I think it's specialist commissioning that we're talking about. And I wonder how much we know about who is running specialist commissioning, who they're accountable to, and what their medical protocols are for making these kind of decisions.
Great question, thank you. Lady in the brown jumpsuit.
Oh, hello. Sorry, I was just...
Well, you're holding the mic, so...
Yeah. I'm thinking about going back to Cass, which, obviously she was incredibly impressive as a sort of monolith against the madness. But I think, it suffered because the language was restrained, academic language. If a diplomat says, Donald Trump is extraordinary, what they mean is he's absolutely ecking Barmo. There's a sort of sense where she said things like, social transition was not a neutral act, and that there was remarkably weak evidence. And there's a sort of sense where the other side have got all the hyperbolic language and not having those, having very kind of that sort of academic speak, which was incredibly powerful if you understood what she meant. But on the other side, they've got life-saving treatment, people who are busy, 40% committing suicide. The hyperbole all over the other side, and all we've got is evidence-based.
Yeah, great. I'm going to take one more question from this side. Lady in the green over there.
Hi. Sorry, can you hear me?
I was going to come to
Can you hear me? Sorry,
yes.
yeah. Sorry, I'm a forensic psychologist in my day job, and I've heard a lot of talk about, sort of the sort of psychological or characteristics of the young people we're dealing with. I just want to add a little bit about the kind of people I work with on a day-to-day basis. So I work with a lot of psychologists who do produce medical legal reports for family courts, and discussions in the last few months have been about how it's far too risky to take on cases which involve gender-distressed children. So they're just simply not doing them anymore, or are most reluctant to do them. I have had many discussions, and I know this might come as a shock, with CAMHS practitioners who have asked me in all seriousness, what's CAS? What are you talking about? I've had discussions with local authority social workers in the last week who've said to me, we can't really question a child's gender identity, can we? It's just not the done thing. People are scared, professionals are scared. They're backing off from dealing with these children who badly need our help. And I just wondered if the panel have any ideas about why that might be, because it's clearly not useful for young people, for the professionals whose job it is to deal with the kinds of problems that they bring to us, to be running away from them?
It's a great question, thank you. And just to sort of speak to that, I think it's not just in healthcare where this is an issue with gender and sex, where you've seen policy change at the very top, but actually not. We see it in schools as well, for example. So schools are not doing things in line with new guidance that government has issued. And I think it's a massive issue on this subject of sex and gender that relates to the way that organisations work, the way that culture works, the way that actually on an issue like this, quite a small number of people in one organisation can frighten others. You see that right across society. And then those cultures become quite hard to shift. But I'm very interested. I'm going to come to you on that first, I think, Anna, actually, because you were talking so much about culture. How can you implement CAS in a world that we've just heard described?
Can you talk about Guardian Media Group?
I don't. I mean, essentially, I think people have to be a bit braver. And once one person's brave, often a few more people are brave. And I hope that CAS has allowed people to be a bit braver. Definitely, when we're working with colleagues, more and more people are sort of saying, well, actually, I've looked at the evidence base, I've read CAS. And that just gives them a bit more confidence to sort of hold the line. How we do it systemically in the NHS, I think that's a really big problem, because I think some people don't want us to implement the CAS recommendations because of their culture and their community and their beliefs and views. But one of our duties as professionals registered by the HCPC standard 1.5 is that you have to be aware of your own beliefs and biases. And I guess, we really need to, call people out in as kind a way as possible. I don't know if I can add.
I just want to add that actually a change in terms of culture, clinical culture, takes time. I think it has already started happening, but it will take more time. And I think it's a leadership issue as well in the NHS, that who is responsible for communicating and disseminating reports like CAS and findings. I know that some CAMs had actually emailed it to all their clinicians and asked them to read it, and they've actually commissioned trainings, and there have been some free trainings as well available in some NHS trusts. So the options are there. The question is who takes the lead on that. And I think I just want to share one of the best feedback I ever got was a trainee who was initially an IAP trainee who I taught their cohort on gender. She was very, very opposing to what we're saying about CAS, and then she got on the clinical psychology training, and she heard exactly the same training for the second time 2 years later. And then she came to me and said, actually, first time I heard you talking and teaching on CAS, I was really angry with you. I thought you were transphobic and all of that. Now it makes sense, which to me shows that some repetition is needed and more opportunities to understand what do we mean by CAS, what do we mean by therapy, because again, some people have some defenses initially and they think that it's all transphobic. I don't think it is.
Great, thank you. Who wants to answer the question about NHS commissioning, which I thought was excellent? Does anyone on the panel?
Well, specialised commissioning encompasses, I believe, about 200 different bits of the NHS. And you're right, GIDS fell under that and the gender services do. Again, most mistakes are generally cock-up rather than conspiracy. And I think that NHS England know that they cocked up here and they were far too slow to act. But I've never seen any sense that there was a conspiracy about it. I think it's a symptom of they just weren't looking for far too long. So going forward, what I fear is someone has still not got an eye on it. You know, when just before I left Newsnight, the last few stories that I did about, setting up the new gender hubs and people tasked with crucial roles, working alongside Anna and Anastasis, didn't agree with CAS and they thought there were no problems. Now, that's ridiculous to be in that situation and to require the media to say that when NHS England knew, but they didn't stop it. So I'm not. So. Yeah, and we do know the people in specialised commissioning who are responsible for gender, and they're the same people that have overseen the huge mistakes of the past. So that is concerning. just to very quickly address some of the other questions, I don't think Cass was too diplomatic. I think that's what made it such a success. And I think, had she used hyperbole and non-evidence-based language, it would have achieved nothing. And actually, when you look at what it has achieved, we have really cross-party consensus in this country politically. Like, God, look across the Atlantic. We don't have that, thank God. And it has actually shifted the dial. There's obviously still further to go, but it has shifted the dial. I think had she done it any other way, it would have had far less of an impact. And a point, talking about being scared to say no to these kids, I think actually this applies in numerous parts of society, like Sonia said, like the adults need to come back into the room, whether that's in parenting, in education, in healthcare. Like, we are there to look after children, not to be authoritarian, but to be authoritative.
Okay, I'll take two. We've got 6 minutes. I'll take 2 questions just to round things off. Lady in the shirt there, yeah, or whatever. No, I can't actually see, so it looked like a shirt from here.
I just wanted to say, well done for raising your head above the parapet. Having lost my job as an NHS nurse for whistleblowing, I know how hard it is. So I wanted to thank you for that. And also to say how much of this is kind of dependent on that kind of culture of the NHS. We're talking about culture generally. It's a culture within the NHS to close down people that speak up. So, and if anyone wants to sign a card for Amanda Pritchard, I've got it with me. But I wanted to say thank you for, because I know it's really, really difficult.
Thank you for that. Right, couple more questions. Can I see your hands? Lady in the blue and blue stripes.
So we know from CAST review that social transitioning is a psychological intervention and not a neutral act. And we know at the same time that in the UK, a lot of schools are socially transitioning kids without engagement with parents or medical professionals. So beyond or in addition to CAST review, is there any other evidence that you're aware of, or any other narratives, articles, research that could help us shift this situation for the better, where these decisions are considered and there is a policy and a process that is well understood and that parents and the wider community is aware of, rather than that continues to be still a secret kept from parents? And a lot of schools have discussions with academy trust boards and lots of people, but parents are not involved. Most parent governors are not aware, and so on.
Thank you. I can see that there is some snacks being wheeled in, so I think we're going to, I'm just going to give the panel a chance to respond to that. I think it's a really important, I've reported on cases where children have been transitioned without parental knowledge, socially transitioned by the school before. I think it's a big issue. Does anyone have any thoughts on how we work with schools on this? I can tell you want to come in.
I think there's also a new school guidance that was out, I think, even before CAS was, which is much more tentative and basically sets the tone that they need to work together with parents. The draft still. And actually, there are also some online modules that have been developed by NHS. Remind me the name? The Minded modules, which are much more tentative. And I usually send it to all schools when they have such cases, because they make it clear that it's not a simple intervention. And it's quite complex. So just to complicate the narrative that sometimes schools have, that it's a one-off thing and it will fix everything.
Great, thank you. Well, all that remains for me to say is a huge thank you to Can at SG for hosting the event tonight. I think it's so valuable to journalists like me who write about these issues to have a clinical network, to have experts on hand to talk to. So thank you. Huge thanks to our panel. You've all been really amazing. We've covered some absolutely brilliant territory, as I knew we would. And thank you to all of you, the audience, because I thought, we had some really good comments and questions tonight, including from people who've got first-hand experience of these issues. So it was a really good conversation. So thank you very much. And I think there's some drinks and food in the corner. So.
People are really upset.